Hi, good afternoon. Thank you for inviting me this prestigious conference in the GWICC and the AHS, Asian Heart Society Congress. It's a really honor for all of us having this conference and the big get together for the cardiologists in the Asia. So yesterday we get the news, more than 20,000 cardiologists joined this conference. So it's really, really amazing how the GWICC and the Asian Heart Society Congress 2024 is ongoing. Thank you again. So first of all, I want to introduce myself. My name is Ms. Bahul Ferdos, and today my topic is dealing with instrument loss in PCI tips and tricks. So today we will discuss regarding stent, balloon, or wire if it is lost, of any kind of trouble or any things happen, how we can rescue and what to do. For the young cardiologist, when we start our career for the intervention cardiologist, I saw many trouble. So most of the trouble, it's a very simple solution, but when we have the trouble, we are very panic and we don't know what to do, and ultimately we lose the opportunities to rescue. So today actually we will discuss how to do prevention, and as a young doctor, what is the best way to deal with the instrument loss. Thank you. So I want to introduce my details. So my name is Ms. Bahul Ferdos. I did my bachelor degree from Bangladesh and master degree and PhD from Shandong University, China, and I did my postdoctoral fellow from one of the best medical school in China is the Peking Union Medical College. And I'm the vice president of the APA, Asia Pacific Angiology Academic Alliance, and I'm the secretary general of the Asian Heart Society, AHS, for the Coronary Intervention Cardiology Council. And at the same time, I'm the associate editor of the US Cardiology Review Journal under Erasmus University, USA. And I'm also the PhD co-supervisor for the Erasmus University, Rotterdam, from Netherlands. This is my short bio. So unwanted situation with the smart solution, that is the main topic. So types of unloading interventional devices, prevention and treatment of device, unloading in coronary intervention, therapy, and finally the prevention we will discuss one by one today. So take out technique. There is a several technique we will discuss today. Number one is a small balloon technique, guide wire winding technology, extended catheter recovery technology, triplet technology, and snare technology. So today we will discuss one by one like how to do the small balloon, because 80% case the small balloon is the saver. I can say 80% case. And the guide wire winding technology also very important for the sometime two guide wire we put and pull and withdraw. We also discuss. And extended catheter recovery technology also one of the best tool for the recovery system. And triplet technology is a very few case, but it's also one of the best tool. And the snare also, it's very common for the cardiologist. We do the snare technology. So today we will discuss very simple way how to rescue and what to do step by step in the different case. So we all know the small balloon technique is the one of the best tool. So single small balloon with the diameter of the less than 1.5 mm and the length of the more than 15 mm was selected, and the balloon was sent along with the guide wire loaded with the stent to the distal end of the stent, and the balloon was extended and 3 to 8 atm, and the balloon was carefully withdrawn to observe where the stent moved with the balloon and entered the digital guiding catheter. So it means first we put the balloon and we inflate the balloon, and step by step we check and slowly move out. So at least 60 to 70% case there is a rescue by the small balloon. Very simple technique, but it's really good, and if we can do the slowly take it out one by one. So this is the animated video, you can see very carefully. So it's a very simple way they are showing like a what to do. It's like a one of the stand is stuck, so now we need to take it out. So please check the animated video. So we pull the small balloon and inflate. Now it's engaged very good way. Now we can pull back. then trouble happen because the guiding catheter angulation not correct. Then little bit, this is the most smart way. The guiding catheter little will pull up, then pull back the stent and balloon. It can come easily. So this is the very small technique, but 60% case we forget. This is the reality. We know everything, why the balloon and why not coming, even it's engaged with the guiding catheter. So the angulation is the most smart solution for this kind of device coming back from the system. So common types of unloading. So there's a the stent is unable to pass through the lesion and it's deloaded when it is sent to forward, and the stent cannot pass through the lesion and it's deloaded when the stent is withdrawn. So these are the common types of unloading device we can discuss in the future. So small balloon pullback technique. This is also we can add. The smaller balloon is sent along with the guide wire to the distal end of the deloaded device portion, and we can inflate at the 8 atm and slowly withdrawn. So capture the trap, choose the right size snare castle. Sometimes also we can use. So entering the guiding catheter along with the deloaded device portion and finally completely withdrawn from the body. So stand extension squeeze and detached part instrument under the basket. So this is the also one of the smart, very simple, very effective in the system when it cannot push forward. So another soft-headed guide wire is fed into the stand through the guiding catheter, and the two guide wires are rotate simultaneously. This is the very small, simple trick. Without the simultaneously, if the angulation we just small way, it cannot be done. So the angulation winding is the rotation with the same parallel same time with the two guiding catheter guiding wire. So this is the very important. And when the guide wire knob to entangle with the distal section, the guide wire gently and continuously retract with the guide wire, so that the stent completely enters the finger guide tube and withdraws out from the system of the body. So when we are doing the guiding wire together too, so we can feel something that now it's engaged. So the feeling pulsation is the key. Until it's not feel pulsation, we don't feel the pressure until we need to do long time. So there is an animated video. It can we can also check. We put the one wire and another wire in the branch side. Now we start the rotating. Until we fixed. And when we feel pressure, then we step back. Again, trouble for the angulation of the guiding catheter. Now little pull up, then the system out from the whole system. So it's one of the best tool. Two things very important for the young people like us. We are the very young doctors. Until we feel the guide wire, when we don't feel the pressure, little bit, we need to do more and more. Once we feel the pressure, that means it's engaged. Then we step by step take it out with the slowly motion. Then we can out from the danger. So double guide wire technology is one of the best technology. We also know is a slide rail technology, was slowly withdrawn from the stent before the non-compliant balloon was dilated under the high pressure. And when multiple stent need to be implanted in diffuse lesion, the slide guide wire can be withdrawn. For instant stenosis, the newly implanted stent should be withdrawn and released when it reaches with the target lesion. So this is the another system like extended catheter recovery technology. So the extension catheter was delivered along with the guide wire still in the unloaded stent to the proximal end of the unloaded stent, and the balloon diameter of 2 mm was pre-placed in the extension catheter. Then secured the guide wire and carefully pushed the extension catheter so that the deloaded stent enters as much as possible into the extension catheter. So adjust the balloon position to the tip of the extension catheter Next spun the balloon anchor stent, then the withdraw to the deloaded stent, extension catheter, balloon guide, catheter, guiding catheter, all together come out from the body. So triplet technology also one of the good choice sometime. So the proximal end of the offload bracket is, the stand is deformed, and it is difficult to withdraw from the guiding catheter. So we push one balloon with the appropriate diameter and length. So the proximal part of the stand is close to the tip of the finger of the guiding catheter as possible with the coaxial angle. Then balloon was inflated with the 5 mm at the tip of the guiding catheter, and at last 5 mm proximal to the stent, the finger guide catheter, stent, balloon, everything will come out together with the system. So this is also one of the some choice we can use. So the snare is the one of the best tool, easy tool. Easy, why it's easy? We no need to do many things to do the system. We just push forward with the safety zone. When we feel we can catch, then just catch and pull back slowly. So many people are feeling comfortable with the snare technology. So this is also one of the good choice when we have the trouble in the stand or balloon we lost in the system. So the snare technology also you can check the animated video, like how the snare technology can be useful very importantly. You can check here the animated video showing. So the stand is stuck in the system, then we push forward the snare, then little bit feel pressure, then move little forward, then catch tightly, very important. Then step by step pull back. Again trouble. Angulation is the most important. Then guiding catheter need little bit pull up for the angle system. Now is okay. So it can come out. So this is the animated video showing how the snare technology is really workable in the balloon or stand when we have a loss or broken. So the one of the system is a break of balloon is a push rod technique. So it's easy to cause push rod fracture. So fracture usually occurs at the junction of the soft hard rod. At this point, the guiding catheter is withdrawn from the coronary orifice, and then repeated negative pressure may be withdrawn from the body. So if not, then it can be withdrawn with the guide catheter. So the balloon broken is a very common in the intervention cardiology. So this is the very common preventive measure we can do in the future. So detaining guidewire technology entry branch should not be too long, can play a role in the marking shake. Pull out paragraph by paragraph, that means step by step. To avoid violence, pulling microcatheter or small balloon support slow step by step withdrawal. So BMW guidewire and hydrophilic coating guidewire welding point is easy to break. So should be used with caution when the guidewire retracting. So beware of guiding catheter deep insertion into coronary ostium. It can be injured the coronary ostium. So we can think about some of the point when we talk about the take-home message. So these are the stent loss, the PCR. Euro PCR talking about the stent loss in the aorta peripheral arteries. So these are the chart. You can take a picture for the more recovery. So if we can the loss the stent identified by fluoroscopy, yes or no. If yes, then if in the cerebral or above the common femoral artery or the below common femoral artery, then there is some treatment we can do. If we cannot find, then use DSA or supraortic CT scan. So if cannot identify, use conservative management. If can identify, then contract neurologist for the retrieval. So these are the common procedure. So we can do for the next. So this is the EuroPCR guideline. If the partial stent loss, what we do. So inflate the stent balloon in the low pressure, then retrieve. So we discuss last few slide this EuroPCR guideline. So if the total stent and guide wire lost, what to do? So pass a coronary guide wire distally to secure the vessel. So most important thing, no matter what happened, the guide wire should be inside the coronary artery. We cannot withdraw the system, the coronary artery from the guide wire. So sometimes when we have the panic attack, we when take it out, sometimes the guide wire also come out. Once the guide wire come out, it's very hard for us next time start the pushing forward with the system. So pass a coronary guide wire distally to secure the vessel. So try to use the snare to retrieve the lost stent, and if failed, cross the stent to the vessel wall with the new stent. Check the stent and balloon integrity after the retrieval. So this is the case one. So we have a shot. So we finish, move forward. So 67 years old female, chief complaint, chest tightness after exercise for the 8 months, hypertension history, hyperlipidemia, no special abnormality, and the case characteristics: the middle segment of the LAD was nearly occluded, and the stent could not pass through the lesion and fell off in the proximal segment when it is withdrawn. So it's a broken segment. So middle segment of LLD almost occluded and calcified. So LC was 90% stenosis in the proximal segment and 80% in the distal segment. This is the CAG report. So proximal RCA 90% stenosis. You can check here. So RCA PCI done very smoothly without any trouble. So is the final result RCA PCI. So everything is okay until this stage. But when we start the LED PCI, then all the trouble come. So EBU guiding catheter and BMW guide were extended after next year. So we are trying to do the LED PCI, and we do the pre-dilatation also. Everything is done. But the stent failed to pass to the turning point and fell off the proximal LED during the retraction. Then all the trouble happened here. So 1.5 million balloon and decoupling a stent, repeated expansion, then everything is okay after this procedure. So angiography showed the distal dissection, like a 2.5 stent was inserted into the stent for the distal release. So the stent adheres the wall properly, then the TB flow 3 is secured. So what are the case summary of the one? The stent cannot pass through the lesion in the middle part of the LAD and the falls of the proximal part of the LAD when it is withdrawn. The stent diameter can corresponding with the proximal vessel lumen. The small balloon gradually expand and release the unloaded stent in the proximal segment. So tortuous, stenotic, and calcified lesion require adequate pre-treatment in the proximal blood vessel and the tortuous. Consider using an extension catheter as soon as possible. Gently push and withdraw the stent. So the another message actually we want to share with all. So the vessel preparation is the most important thing, no matter small or large calcified lesion or whatever. So if we don't do the proper vessel preparation, no matter we put the balloon or no matter we put the stent, some danger can occur immediately. So we can focus more and more. If the calcified lesion, we need to do the rota. If they have the no rota, then we need to find the other way. So, but the vessel preparation, we can focus more and more, then we can avoid many unwanted trouble in our daily practice. So case number 2, 75 years old, chest pain for the last 1 year and worse than last 1 month is more and more. So inferior wall myocardial infarction 1 month ago, thrombolytic treatment in another hospital. History of hypertension, diabetes, cerebral infarction, and the gallbladder stent they have. So I think LAD and LCX quite okay. Yes. So the LAD and LCX, there's no visible abnormality. 90% stenosis in the distal RCA and mid RCA tortuous. So please check again. So the tortuosity on the mid RCA is huge, but the distal RCA 90% stenosis. So it's a little bit challenging to cross the mid part of the RCA. So the also one of the problem with descending out is severely deformed and there's no support for the guiding catheter. So guiding catheter coming out and go. So it's a really hard job to fix with the RCA. So 2.5 balloon pre-dilatation done. When the stent we release, then the balloon rupture occurred in the middle of the RCA because the tortuosity, then this is the not common but happened. So then again, 2.5 balloon and 3.5 post-expanding balloon for in the C2 situation. We do inflate and unload the stent and continue the implant 3.25 stent in the lesion site. So after release the stent, there is no hematoma. That means distal blood flow, good, TME3, 3, secure. So the case summary 2 is that the balloon ruptured during the release of the stent and fell out from the middle of the RC during the withdrawal. So no need to insist or withdrawal from the outside. Coronary blood flow is the first priority. So early use of extended catheter for the tortuous vessel when using Godzilla, special care should be taken. So these are the message from the case 2. So the take-home message, the very important for the this kind of problem. Pay attention to the below point in the daily practice. Severe stenosis, tortuous lesion, adequate predilatation should be performed. Severe calcification, use rota. So there's a many other device come in the world, but I strongly believe the rota is rota. So try we can use and more and maximum time we can use the rota if possible for the calcium calcified lesion. So choose the appropriate guiding catheter to ensure coaxiality and sufficient support. So without the support, all the trouble come even with the good device. So during the withdrawal and insertion of the stent, please gentle and avoid excessive force. After the problem occurs, cardiologists need to remain calm and keeping the guide wire inside the stent is the key to subsequent treatment. To choose the most suitable strategy according to the specific situation of unloading and minimize the adverse consequences. So ensure the coronary blood flow and hemodynamic stability is the first priority of the any procedure. So these are the one of the things we are trying to do with the AHS, Asian Heart Society. We already submitted. So the Hridoy BRI, one of the APP, there is a the inventor of the APP, Dr. Sakif. He is here today. So Dr. Sakif. So he is the actually inventor of this APP. So we are trying to do this APP with the name of the Belt and Road Initiative to extend our cooperation with the many countries under the guideline, under the support, under the umbrella of the AHS. So we plan the action plan, prepare own mobile app, and collect the patient data and evaluate the health hazards. And all the hospital director will join this project and project year from 2022 to 2023 July. So we already submitted and get together more than I think many hospitals and doctors training, joint research program, big data bank, AI for the COVID-19 time also we use this system. So thank you all. Thank you for listening. Thank you for inviting me, and thank you all the doctors and cardiologists. So this is my number and contact email. Thank you. Thank you, sir.